All right, everyone, the time now is 33 minutes past the hour, and so we'll go ahead and get started with our presentation today. My name is Lynn. I am the Inclusive Strategies Manager at CityMatCH, and Denise and I are calling in from Omaha, Nebraska, which is on the ancestral land of the Omaha and the Sioux tribes. And today we're featuring Kay Johnson in our June installment of the Region 5 Infant Mortality webinar series. But before we get started, I just wanted to go over some light housekeeping. So today we're using Zoom webinar, and so we have the use of the Q&A function. And so throughout Kay's presentation, if you have any questions that come up, feel free to enter your questions into that Q&A box. You should see it at the bottom there, where you see like the chat, the participants list, and all of that. And then during the presentation, I'll disable the chat function so that we can minimize the chatter happening, but I will re-enable the chat function at the end so that we can have a conversation with Kay, so that you can enter comments, any additional questions or anything. But keep in mind that the Q&A box is there throughout the entire duration of our presentation today, and feel free to make great use of that. And so today we are delighted to have Kay join us. Over the past 35 years, Kay Johnson has become nationally recognized for her work in maternal and child health. She is an advocate, a researcher, a consultant, and reducing the impact of poverty and racism and increasing access for women and children are two of her lifelong goals. Kay is president of Johnson Group Consulting, and her expertise encompasses a wide range of issues. Her work at the Children's Defense Fund, the March of Dimes, George Washington University, and Johnson Group helped shape the direction of MCH and Medicaid policy since 1984. And prior to her policy career, Kay worked with families in early care and child education. And so with that, Kay, I'll pass it to you to share your expertise with us today around policy work. Thank you.
Thanks so much, Lynn, and thanks to you and Denise and CityMatCH for inviting me. I'm going to start sharing my screen. While I'm doing that, I will just say, let's just get the slideshow started here. I'm going to stop my video so you can focus on what I'm saying. I am speaking to you today from Vermont, and the traditional custodians and indigenous people of Vermont are the Abenaki Nation, who are part of the Wabanaki Confederation, an Algonquin tribe, who've not been fully acknowledged by my state and therefore by the federal government, still a work in progress. And many of you have had an opportunity to meet my husband, Robert, who had a grandmother who was an Abenaki taken from her tribe and adopted by a non-Indigenous family. So it's a tradition that I'm very aware of here. So I'm going to talk today about seizing the moment, about action and advocacy. I'm going to talk about what's going on in policy, and particularly in Congress and the Biden-Harris administration. And I really just want to give you a sense of what you can do in this moment, besides watch the news or listen on webinars. I really am honored to be a part of this Region 5 series. Many of you know that I come from Indiana and I follow what happens in your states out in Region 5, but I'm also particularly honored for this series to follow people such as Dr. Art James and their brilliant analyses and recommendations. Just another way of looking at me, besides the nice bio that Lynn read, is about what I believe. I believe that equity depends upon strong and well-implemented public policies, that every person should have the freedom to decide if and when to be a parent and raise a family, that reproductive justice will be attained when all people have the economic, social, and political power and the means to make decisions about their bodies, sexuality, health, and families, that clinical practice changes, quality improvement, or individual behavior change are necessary but not sufficient to improve outcomes and in disparities, that to have equitable impact on the greatest number of women, children, and families, we must ensure effective public policies, programs, and services, and that the data are not now and never have been neutral, and credit to that last point to Nancy Krieger, who has written several books on that topic. So let's talk a little bit about recovery. You know, this picture, I don't know, it says it all to me. We're putting our heads together. We're screaming for joy. We're out there without our masks. We're vaccinated, like hopefully all of those young children are. But what does the COVID-19 emergency meant for families? And we know with crossing the 600,000 death mark that we're not out of this. There was a piece in the New York Times this morning reminding us not to say, that we're beyond the pandemic when so many people continue to die here and around the world. But and it has disrupted the lives of virtually all children and families, but it really presented greater challenges to those who are economically fragile. Those people without wealth and those limited by structural racism had less in emergency savings, fewer places to borrow money, less home ownership, more risk of eviction, less likely to have equity in a home against which they might borrow, or a home to sell for which they could get the full value, that they had greater chances of losing their job and more pressure to continue working away from home in less than safe situations. In order to get us to ensuring equity and shifting the social determinants of health that leave people in those situations, we really need public investments. And on the right, this is kind of a rough headline view of the WHO framework for social determinants of health. My diagram, their topics. So structural determinants, intermediary determinants, and direct care determinants. So in that structural, as you know, likely we're talking about the policy and social context. We're trying to get to more opportunity, more justice, more income and intergenerational wealth. And in the intermediary determinants, we're trying to get people to better living conditions, more safety and well-being, to enhance family strengths and positive experiences. And in the direct care determinants related to health, we're talking about reducing unequal treatment and increasing access to quality, comprehensive, team-based care. In order to get to all of those things, our public policies and our investments need to eliminate child and family poverty and raise opportunities, provide for basic needs for those who can't provide them for themselves, to support and strengthen families and aim to do that in a systemically positive and equitable way, to promote positive experiences at home and in communities, and to improve health across the life course for women, children, and families. The first chunk of my talk today is going to focus on the American Rescue Plan. And what you can see on this slide is kind of a collage or montage, and I love the way that the points that were highlighted by Bernie Sanders, my senator, are very similar to the points that were highlighted on Fox News. Today, when I talk about the American Rescue Plan, I'm talking about what the president proposed. And when I talk about what Congress enacted, I'm talking about the American Rescue Plan Act. So just to give you a sense, there's a headline about cutting child poverty in half, and we're going to talk more about that. But where did those dollars from the rescue plan go? The biggest bunch is in this purple wedge with those $1,400 stimulus checks. The aid to state and local governments to reduce layoffs and service cuts, the next largest tranche there. Unemployment insurance, a big chunk of money dedicated to that, even though some states have now turned back that money or declined to take it. The next largest wedge is the tax credits, aid, and childcare for families, and I'm going to say more about all of these things. Reopening schools, again, the next largest, then the vaccinations and healthcare, and a variety of other things in those smaller areas. This is the biggest shift in child and family policy in many years, arguably maybe 25 years since the Clinton-Gingrich shift, which was a negative shift in our social welfare system, in 60 years since the Great Society and President Johnson, or in 85 years since President Roosevelt and the New Deal. The thing that's amazing to me as someone who studies the politics of policy for families and children is that this shift toward policy is designed to help a wider array of families. It's more like what European and other industrialized countries do. It doesn't say you have to be a single parent. It doesn't say you have to be the poorest of the poor families. It is less discriminatory and more equitable by race than many of our previous deals. big social policy shifts. And it's really remarkable in that way. People whose families were disrupted could see immediate relief through an array of supports. And the American Rescue Plan Act included many one-year improvements on a pathway to end child poverty in a generation if, and it's a big if, these policy changes can be made permanent, and we're going to talk more about that. I generally like to cluster what's in this act into 4 buckets. One is about economic relief to families with children, and that's predominantly in tax credits. The president proposed and the Congress did not adopt the minimum wage. But that bucket also includes the direct relief checks to families and the unemployment benefits. Then protecting health and health coverage through Medicaid, protections, the postpartum coverage we'll talk more about, reducing the Affordable Care Act plan premiums, augmenting the workforce, the safety net, the vaccine campaign, and pediatric care and other mental health. And then assistance with basic needs in income, childcare, utilities, food. I've put home visiting there, and housing. And then opening education settings safely from 0 to 21 and beyond, whether it's Part C early intervention or childcare stabilization or the hardest hit K through 12 schools or higher education emergency relief. This is a table that was prepared by Charlie Bruder in Ink Marks, and he's given us an ability to use it. And what you can see here is in those billions of dollars of investment in women, children, and families, and that title it should be all orange. There's no distinction to be made in the fact that there's a color change in the title. But you can see $7 billion for the public health workforce, $7 billion for community health centers, $3 billion for mental health, $150 million for home visiting. The child care tax credits add up quickly. The education money adds up quickly. But this is a lot of money. These are really big investments. So I'm going to show you some details as we go through, and some of you may have seen these, but I've changed the slides a little today if you've seen me do some of this ARPA talk before. But I think these to-do lists are for you. You're for people who are advocates at the state and local level, people who deliver programs, people who make program and policy decisions in maternal and child health agencies, people who deliver healthcare and other direct services to families. So your general to-do list is to find out how the American Rescue Plan Act policy changes may impact your state and community, to understand how these changes affect families or services for those you care about, the populations in MCH, to inform your state and local decision-making about implementation, to get staff trained so they can support and inform families like navigators and care coordinators and home visitors, educate the people you serve about these opportunities, connect people to other resources, and we'll talk more about that, but that one stands for volunteer income tax advocates. There are 5 expansions to tax credits. You won't become experts on all of them, but we have volunteer income tax advocates who are experts. And using, the community partners to help inform. That should not say DMH SMI. So if we look at the tax and income supports first, the various kinds of tax credits listed there, the unemployment as well. So your to-do list is to understand the differences and the changes in the kind of tax credits, just to understand them at the macro level, like the level you learn by reading the newspaper, or you may want to go to briefs. I've given some links to the federal resources, but the Center on Budget and Policy Priorities and other organizations, the Children's Defense Fund and the Center for the Study of Social Policy have a special initiative around the child tax credit. So there are lots of ways to learn about this. And then to inform families about their tax credit opportunities. Families can start getting money next month. They can start getting these tax credit checks in their bank accounts and their mailboxes next month. Many families won't know that. And many families who low-income families who didn't file taxes won't automatically get it. So helping them figure out how to connect and helping them with other legal partners, income tax advocates, and other resources so that they can get this credits. 90% of all children can benefit from this tax credit expansion. That's how big it is. Among those, 27 million would be lifted out of poverty. And this is the overall impact data compiled by some really good folks at Columbia University. And you can see when we talk about cutting by half, you see what's happening over on the left for all children, but also look, it's by more than half for Black children. It's by nearly half for Latinx children, and it is not quite half for white children. So this will have profound effects, but particularly for children of color. Some of you have heard me talk before about the Earned Income Tax Credit and its role in improving MCH outcomes. There's an increasing database, and I've got some more citations here that are newer than some I've used in the past. So the Earned Income Tax Credit shows evidence of improving maternal and infant health, of having better school performance for the children who got this in their early years, and for those who had benefit of an Earned Income Tax Credit, more income in their family in that generation, increased college, work, and earnings. For the kids who had it when they were young, those are their outcomes. Now, to me, this list looks like a lot of what we're promising with home visiting, but in MCH, we are talking a lot about home visiting and its promise of outcomes. Most of us don't talk about the Earned Income Tax Credits, or we think the child tax credits will have the same impact by just putting money into families' pockets. For many, many years in my career in public health, we said, there's nothing we in public health can do about poverty. Well, now there is. The American Rescue Plan Act has these emergency assistance, again, through the relief checks, the enhanced unemployment, and assistance through income, food, childcare, housing and utilities. The food benefits, that money needs to get sent out the door this summer, and it's going to provide a real boost for particularly through WIC in fresh fruits and vegetables for families over the summer. And so it's something that's almost an urgent action for that money to go out the door between now and the end of September. So training your staff, whether that's a health department or a hospital or a clinical setting or a home visiting program, informing families about the kinds of emergency assistance. There are some good basic handouts about that, or you could make one or have a little checklist. Confirming that families got their COVID relief check, they should have gotten one by now. Connecting families to WIC, SNAP, and TANF, and telling them that they could get, if they're in WIC, for example, they could be getting a bigger benefit for fresh fruits and vegetables, and perhaps people qualifying for SNAP who did not qualify before, and using your community partners, obviously, to get these jobs done. The Biden administration has a lot of priorities on health coverage. They've used executive orders, agency action, and legislative action. The biggest thing here to mention on coverage overall is about the special enrollment period to August 15th. And the fact that the American Rescue Plan Act lowered the premiums for most people enrolled in those marketplace coverage plans means that even people who went there before who didn't think that they could afford the premiums, most of the premiums are about half of what they were if you looked a year ago. And again, this special enrollment period is likely to run out in the next 6 to 8 weeks. What are we? We're at about 8 weeks. And so getting families to know this, I discovered yesterday that one of my nephews could qualify for this. Because he's had a period of unemployment and he's been paying out of pocket for his coverage and didn't know that he might be able to go in and qualify. So the American Rescue Plan Act and the ACA coverage checklist is to check out healthcare.gov or your state insurance marketplace website. If you go to healthcare.gov, it'll link you to your state website. I just did that at a glance to see what it tells people. Ask people about their need for coverage. It's not a topic we talk about over the kitchen table very often or in a lot of community and neighborhood settings. Um, Informing families about the special enrollment period and helping people with the online enrollment process. Most of this enrollment has to be done online. I don't think it's as simple and straightforward as it could be for people who are on the other side of the digital divide. It's not easy to do on your phone, for example. So figuring out if your agency can help, or there's a library or someone else who's helping families with this. There are also provisions specifically related to Medicaid. The one that all of you likely know about is the option to extend postpartum Medicaid and CHIP coverage, but there are also incentives for states to do more Medicaid expansion, the mandatory coverage for the COVID vaccines and treatment, and home and community-based services for people with disabilities, including children with special healthcare needs and disabilities. So the postpartum care to-do list is supporting postpartum Medicaid and expansion in your state. And I am widely encouraging people to move their state policymakers toward the discussion of a state plan amendment. Many states, particularly out in the Midwest, really, obviously, the great success in Illinois of being the first to get their waiver approved. But the advocates in Illinois know that they're making a rapid pivot toward the state plan amendment because the state can get more money, more people will be covered, and the benefits will be better under the state plan amendment than under a waiver. Learning about the postpartum coverage loss among the people that you serve, the people in your state, and helping birthing people get timely postpartum care. We know that coverage doesn't immediately translate into access. So how are we going to implement that new policy? These data are a little bit old, but there are some updates to it that reflect a similar pattern. And so among the data compiled by the Urban Institute, uninsured new mothers with a baby, these are the people they lost coverage. Why did they lose coverage? Why were they uninsured? You can see almost half of them were uninsured because they lost their Medicaid post-pregnancy. Others couldn't afford it. Others lost a job or changed jobs. And there are other reasons, maybe a dependent coverage issue, some other factors there. Half of this total group had below poverty income, which means half of them weren't poor. Half were Hispanic, 2/3 were citizens. More than half were married and another quarter lived with a partner. And while 1/3 were employed, there was another big batch not in the labor force. That has likely worsened during the COVID era. But what we know is that getting this Medicaid expansion will solve a lot of the postpartum coverage loss. Medicaid coverage for infants, equally important. I'll talk in a moment about what I did. I have been widely saying in all the child health meetings that I attend and the things that I write that we can't fix equity unless we fix Medicaid. We aren't going to get health equity or care unless we get the Medicaid program to perform and to hold providers accountable and to hold health plans accountable. More than half of all babies, 2.2 million infants, are enrolled in Medicaid. Now, we have about 3.9 million births. 2.9 million babies are in the Medicaid program. And that is 6 out of 10 Black, Indigenous, and Latinx babies. And overall, half of Black, Indigenous, and Latinx children of all ages are enrolled in the Medicaid program. Getting them the coverage is not enough. We've got to work to get these programs to perform and to hold, as I said, plans and providers accountable. Earlier this year, I released a report about babies who were not continuously enrolled in Medicaid. The federal law guarantees automatic and continuous enrollment for babies with a Medicaid financed birth. They shouldn't have a break in their coverage. I've used Delaware here as an example, but it's 500,000 babies per year in the United States fall through the cracks in the enrollment process. So what can you do? You can review my report. There's an executive summary, there's a blog, and there's a longer report. Thanks to someone in Illinois yesterday, we discovered that I had identified some contract language for Kansas as from Illinois, and we're going to fix that. Look at your state website. Part of my study process was that I looked at every state's website to see how did they inform families. What did a family see when they go there? Does it say clearly if your birth was financed by Medicaid, your baby is automatically covered for a full year to their first birthday? Most state websites do not say that clearly. Some only say it on the pregnancy page. So if they go to the child health page, they don't see that information. Informing families about automatic and continuous eligibility. There are some providers, so for example, out in Orange County, they made observations that there would be babies who came in and their first couple of visits they were on Medicaid, and then the next couple of visits they weren't. Those observant FQHC providers in Orange County, California, identified that it was a systematic problem, that it was happening statewide, and that thousands of babies were being kicked out by the computer system for reasons that didn't make sense. So talking to families about the fact that the babies should not be losing the coverage during that year. And then helping the families confirm that the infant is enrolled. Most states have a phone number or a website place where you can do that. The American Rescue Plan Act also has these investments we talked about in the public health workforce and community health centers for directly to public health agencies, and another almost $50 billion for COVID testing, contact tracing, and mitigation. That's a lot of money, people. And the decisions are not always so transparent. So are some of these resources going to maternal and child health purposes? Are some of those public health workforce roles and investments being made in the maternal and child health workforce? Ask the questions. If your governor is still having COVID briefings or your mayor is still having COVID briefings, get somebody, a reporter, to ask those questions. Ask the questions through your legislature. Ask for transparency in how these dollars are being spent and whether families with children and birthing people are going to have an advantage in this. So learn about what your state's doing, encouraging the hiring of family specialists, community health workers who work in maternal and child health, and encourage workforce development that supports those families. Not going to go into the details of home visiting, but again, there's $150 million to help with all that pivot to virtual visits, also to help get families emergency supplies. So I'm shifting just for a moment to the American Families Plan. This is a proposal. And what you can see up on the right, I love this moment where the president had Madam Vice President and Madam Speaker behind him, two women for the very first time in our nation's history. And he made the case for the expanded role of government for families. This is the first focus for children, a list of highlights. I've highlighted similar things on my slide. The biggest thing would be to make the child tax credit and other tax credits permanent, that it would continue to provide assistance and support. I know many of you are advocates for paid family and medical leave, but also for premiums and support, and a big boost for education. So there also are pieces, I didn't mention the American Jobs Act, but there are childcare and workforce provisions there. So the American Rescue Plan has been passed with most of its major provisions intact, except the minimum wage. The American Jobs Act, that's the infrastructure bill that you may be hearing about in the news, and that's sort of moving, and we'll see what comes out of it. And then the American Families Plan, already proposed by the president and sort of up next on the congressional agenda. And I think, what does this mean in terms of improving the health and survival of mothers and infants? And to me, it's about particularly addressing social determinants of health. So provisions around how these together, housing in the built environment, income and economic stability, safety and emotional well-being, parenting and social support, education, and whether that's child care, early care and education, or whether that's continuing education for a young parent or educational attainment, all of those elements, and both health and healthcare. Um, Actions in all of these areas across the Biden-Harris agenda for how we're going to help families do better in our society. I think you as MCH leaders can leverage the investments that are in these. You have community partnerships, you have opportunities to leverage change. You're the ones who are most likely to braid funds. You are at the point of inflection, and I've been hearing people say that for a while, and I sort of said, well, do I really understand what a point of inflection is? Well, here it is. It is when the curve goes from that down to the up. So you are at that point of inflection, and we are at that point of inflection where we could start to see a real shift in the way that we support birthing people, families with young children, and families overall. So I'm going to shift now to talk about why this is the time to go farther and to do better in maternal and infant health. And I'm keying into the quote from Maya Angelou about do the best you can until you know better, and then when you know better, do better. And I think many of us and many of you have been have known things for a long time, but other people are learning and know better. And how do we leverage that new awareness and knowledge among a broader sector of our policymakers and the general public, particularly about maternal mortality and infant mortality and the risks to people of color, particularly Black women, in today's healthcare system. So when I think about a time to go farther and do better, I just like to step back and say what we've been doing was incremental, and it was really limited by the socio-political context. We have not been investing in whole families. It's not reflective of women's voices. It did not acknowledge or address bias and racism. It did not share power with women, families, and communities. And I think about the family member who, at our infant mortality coin meeting in 2015, wrote on we had a board for just people to go up and write what they were thinking about. That we deserve the opportunity to have families regardless of the financial ability, and gets to that notion of reproductive justice. So the Black Maternal Health Caucus introduced the Momnibus, and if you don't know, I love the twist on this, that an omnibus bill is a bill that combines of a lot of other pieces. And President Reagan was one of the first to use an omnibus budget reconciliation act to do harm. And I just love it that the Black women members of Congress took that notion and flipped it to call it the Momnibus. You can see there a variety of the members of Congress and other policymakers. The caucus and the supporters of the Momnibus have grown. There are all kinds of people, even a couple of Republicans who support the Momnibus. So this is from last year. The Momnibus had 9 component bills, and there were an array of additional bills. I'm gonna move forward. I wanted you to have this in the slides, but this is this year. And remember, we're still early. We're only 6 months into the 117th Congress, which will last for 2 years. So the Momnibus now has 11 components, adding a maternal vaccination component and adding a climate change component onto the things that were introduced last year, the original 9. And then the related legislation in Congress, a lot of these are bills that have been reintroduced. But if we get down here, we've got, let's see, I think I've got a pointer, a stamp, a drawer, or something. Let me get the mouse. So can you see the mouse now? Let me get it. Let me get something to draw with. So we've got down here, oops, no, that's not working. I give up. I give up on showing. Down here on the list, we've got, again, immunization, oral health, data mapping, more bills with Medicaid in it, more bills to address rural aspects of this. Um, so if we think about all of those, basically, in sum, these are the bills introduced last session, and it's adding up to the same thing for this session. 3 buckets. One is coverage. The postpartum coverage option for states, which was passed, but making that permanent is still on the agenda. Incentives for extended postpartum coverage. Do we need to further incentivize states to do it? Or actually, there's some of those bills that really talk about innovative payment models or ways that that coverage can be leveraged. There's a whole array of things that have to do with a bucket I would say is quality. So investments in perinatal quality collaboratives, provider training, workforce expansion and diversification, the pregnancy medical home or care coordination bills, data and quality measurement, and grants to states to implement best practices. And that would include surveillance through CDC, maternal mortality review committees, the AIM grants to states, a variety of things such as that. And then in terms of social determinants of health, a lot of the Momnibus provisions call for an interagency task force on social determinants of health, as well as reports from the National Academy of Sciences, Engineering, and Medicine, the Government Accountability Office, and the Department of Health and Human Services, the Veterans Administration, the USDA on food, on justice, and other departments. It really calls across departments for people to look at the role of social determinants and factors about women's lives that are driving maternal mortality. And it also gives emphasis to community-based programs, some bills through grants, or some to technical assistance, and many with emphasis on community-based organizations that are in traditionally underserved communities or operated by people of color or traditionally underrepresented leadership. Let me get back into slideshow. Sorry, I bounced out. So thinking about what it's going to take to get us to unequal treatment, obviously those policy changes are really important, but it's about layers of change. So improving coverage and benefits and reducing the cost to women is obviously a big threshold. But addressing the role of racism in access to equitable care for Black, Indigenous, and other people of color is going to be equally important work for us to do. Implementing practice guidelines, and I'm going to go deeper on that in a moment, that what we know is that women of color do not consistently receive care according to practice guidelines. And you can help document that, and you can help change it. Adopting anti-racist, anti-bias approaches in healthcare and designing and conducting improvements with an equity lens, not just to measure disparities at the end. Can someone let me know you're still hearing me? I just got some static on my headset. I hope I'm not
Yeah,
wrong.
we heard the static too, but we can hear you, okay?
Good. Okay. So looking at this graph begins to get us at some of these issues, particularly the practice guidelines. So this is just one. You can get a lot of these kinds of examples out of your own state PRAMS data. This is from a CDC analysis of PRAMS data for the country, and basically saying, did women get preconception advice on achieving or preventing pregnancy? Well, first of all, look at the scale. We're only going up to 8%. So we're not even talking about 10%. We're down here in the 1 to 2%. But even at that level, look, we have the gaps by race and ethnicity. And then if they go, the PRAMS questions go on to ask, did women get medical services beyond advice? First, did they get advice? Almost none of them did. And then did they get services beyond that advice about, helping them achieve or prevent pregnancy? Look at the gap by race and ethnicity. It's really just unacceptable. This is guidelines work. There are other graphs that show us that in the prenatal period, there are gaps both by race and insurance source that women do not get standard of care. And so, even if we start by bringing forth the data about the fact that women of color are not getting care according to practice guidelines, we can begin to drive this part of the conversation, which we haven't driven far enough yet. So a lot of you have seen me talk before about large P and small p policy examples. We're going to go beyond policy into practice and programs today, but clearly adopting these policies to improve social determinants of health and well-being is a critical step, and now we need to get them implemented and permanent. Extending the Medicaid eligibility for 1 year postpartum, getting those federal agency changes that are outlined in the Momnibus bill and the HHS action plan, making sure that our safety nets and community-based sources of support for women have funding, thinking about the community-based MCH workforce, such as doulas and community health workers, and not cutting funding as a result of COVID-19 budget changes. Small p policy examples, building the workforce and reimbursement for community health workers, navigators, doulas, and others who may be providing care coordination. Incentivizing patient-centered team-based care in medical homes and carry on through that, particularly related to well woman visits. The Affordable Care Act required certain preventive services without cost sharing. The law did not extend that to all women in Medicaid, and it's up to each state to do that. Having interconception or postpartum care projects for those already enrolled. If your state doesn't expand eligibility, you still have some of the poorest high-risk women who continue past 60 days, and we could be doing project development and responses for them. Thinking about the Medicaid managed care contract provisions and using perinatal quality collaboratives to advance equity, not just doing a generic action and measuring the disparities at the end. Our program strategies in public health are related to changing the culture of health and healthcare by promoting reproductive health and autonomy and respectful and meaningful partnerships, using an equity lens to assess and modify our programs, policies, and practices, starting with ourselves in public health, and getting our workforce trained up in understanding root causes of inequity and anti-racism, shifting from monitoring behavior toward listening to and supporting women and families, adopting a state or city county strategic plan aimed at birth equity, focusing on social determinants, and collecting and using data by race, ethnicity, income, and insurance status to monitor quality. We're underusing our data. Practice strategies about making sure that when we're talking about medical home, the word equity is in that sentence. It often is not, but it was in the original Institute of Medicine report about quality, and it should be every time in the sentence that describes primary care and the medical home. Identifying and addressing the structural barriers to care that obviously includes racism, making practice changes. I really like this from the ACOG statement, that they say it is the responsibility of individual OBGYNs to combat racism, racial bias, and achieve inclusiveness in our own professional settings, to build awareness and seek remedies to protect practitioner bias, recruiting and training more providers from racial ethnic groups that are underrepresented and who reflect the communities served, so we have more cultural congruency, and engaging with others on issues of equity with the expectation both in the ACOG and the American Academy of Pediatrics recommendations that providers will engage with others who are leaders in these issues. I'm just going to bring us close to a close here, talking about measurement strategies. Many of you have seen the framework we developed for the infant mortality coin on monitoring social determinants of health and health equity related to maternal, infant, and family health that was really aimed at thinking about maternal and infant mortality. I want to bring us back to that. I've been busy doing a lot of other work, but I am still continue to be a very strong believer. I presented this at several CityMatCH meetings and APHA and other meetings But we've got a set of domains where we should be measuring. We've got these set of measurement topics. Everywhere you see a purple circle, there is a measure. And there is a measure that is an existing measure that can be measured for for virtually every state on every measure, and almost all of these down to the county level. The other thing that this framework does is that it adds a care equity measure topic. And this to me is about the unequal treatment area. It's not enough to just measure our family planning or our prenatal care or our postpartum visits. We need to be measuring them by race, ethnicity, income, and other factors where we know that there are discriminatory issues. We have to move beyond just measuring our disparities in birth outcomes again and again and again. We don't need to stop measuring those. We want to be able to show progress if we can make it, but we really have to stop just saying, oh, there's a disparity. We measured it and feel like we did our job. We need to measure these other things, and we in public health have the capacity to do this. You can let CityMatCH know if you need more details about this or you're interested in the list of measures. I think using this framework with social determinants of health and equity sets us in a broader context, and many states and local areas could be doing this now. So I think you can have a tremendous impact on the future through policy and what's happening now. I really do think we have to seize this moment. Frankly, the midterm elections may change the Congress. We have to make these things happen now while they're within our reach. We need to act with urgency. Many of these opportunities are only for 1 year, and if we don't get Congress to make them permanent next year, we may lose the opportunity to do so. You can help guide the decisions in your states. Ask questions, get others to ask questions of your legislators, get the media to ask questions for you of the policymakers. Implementing policy from your role, and whether your role is in direct contact with families, or your role is collecting data, or your role is actually running the program, implement the policy from your role. Assist birthing people, families, and youth in understanding and benefiting from the changes in policy. And if you aren't the person who has direct contact with them, make sure that the people who do have direct contact with them have information, knowledge, and tools to assist in this kind of informing. Educate decision makers about the importance of social determinants of health and responding to concrete needs. It matters if pregnant women, new moms, and babies have a home, have a safe place to sleep, have shelter that is adequate in terms of heat or cool. All of those things matter. And some of this legislation that I shared with you at the federal level, including the Momnibus, begins to make a wide recognition of that. But very often it hasn't been fully explored at the state level, and there's a big opportunity there. Advance anti-racist, anti-bias practices, programs, and policies. That's really going to happen much closer to the ground than what Congress can do, or even often than what states can do, although states clearly have a role in this. This is much closer to the community level. And really just having us do better now that we know better, and bringing other people who now know better into alliance with us in this work. I think it's a tremendous moment of opportunity for change. We know that the death of George Floyd created new allies for working against racism in our society. We know that the drumbeat around the tragedy of maternal and infant deaths, particularly among Black families, is really leading to a sense of change in congressional awareness and state policymakers. We need to keep up the drumbeat and keep engaging with those other people. So I'm going to stop now for discussion and questions. We've left a lot of time to do that.
All right, thank you, Kay, so much for a wonderful presentation. We do have a few questions in the Q&A box, and then in the meantime, let me activate the chat box. Okay, so The first question that I see in the chat box asks, why does the EITC lead to better school performance?
Well, it leads to better school performance and maternal and infant health outcomes and better, better jobs and completion of college and all of that because it puts the money into families' pockets. There was a very good webinar recently by the National Academy of Sciences from the group that put out the report on the roadmap to ending child poverty. And one of the speakers was extremely eloquent in saying how families spend that money, whether it's the EICT or the child tax credit, is a whole series of investments. If it's getting a better car so the parents can get a better job, if it's investing in enrichment, getting better quality childcare, a whole series of things that families can do if they have money, and money that isn't tied to just buying food or just paying rent. So it creates opportunities for families to invest in their children and in their own well-being. Maybe the parent goes back to school because they have time to do that. I think it's those factors that make the EITC work. It's putting the money into the pockets of the families and letting them invest in their own success and their own self-sufficiency.
Yeah, that's a really great point. Thank you. The next question says, are there innovative projects or uses of ARPA, or future funding to eliminate inequities in infant or maternal mortality among racial and ethnic communities you can share?
So let me just back up and say, I think it's at 3 levels. So one, in the American Rescue Plan Act, all this money for community health centers, community workforce, safety net. If we don't make our voices heard, that money will not necessarily be invested in maternal and child health. It might go to nursing homes. It might go to adults who are homeless. It might go to people who have chronic conditions who are at higher risk for COVID. But we can make the case for that money, being invested in community health workers who support maternal and infant health. If we make that case, I think there is sufficient money in that pie that we will get some of that money for that workforce because of the interest in maternal and infant health right now. But public health departments at the state level are going to go for the quickest thing they think they need for COVID, and they aren't going to think about it as a long-range investment. So we really need to make that case. The second aspect of that question is, again, in the omnibus and in about a half a dozen of the other bills that I showed you, there are funds proposed specifically for investing in community-based organizations in traditionally underserved communities for traditionally underserved populations. They have made it as directly as they can in federal law that they want it to go to the non-traditional groups that don't always qualify for the big federal grants that really are doing the work in communities with some of the families that we are most concerned about. And I think obviously then how do we use the coverage in Medicaid, the postpartum coverage? How do we engage and train providers in delivering better postpartum care? Most postpartum care is not up to standard. Most of it's not being equitably delivered, nor are the well child visits that you'd want for the woman further on in that year. Where are we going to get the chronic care models for the women who have the diabetes or the hypertension or the cardiovascular conditions that place them at higher risk for dying? We're going to have to build the care models. There's money there, but in order to use that money, we've got to have the providers doing the work.
Excellent, thank you, Kay. The next question says, how well are states implementing practices to help dispel infant mortality? How is Medicaid making changes to bridge the gaps and make sure that changes are lasting?
Well, again, I think that quite a few states are going to use the extended postpartum coverage. Some of them are going to do it because they don't want to expand Medicaid overall. Some of them are going to do it because they're thinking about the importance of this. But again, I think that we'll get those Medicaid expansions. The coverage will be extended to the women. It will be up to providers and maternal and child health leaders to build the care models, do the provider training, reinforce the quality, get the managed care contractors and plans to focus on this as a priority, get a measure of postpartum visits. We don't use that measure, postpartum visits, very much. I bet most of you have never gone to look at the difference among health plans. Actually, I know some of you have, but I bet most of you have not gone to look at the difference in the managed care plans in your states. The gap between some of them performing well on postpartum, some of them not so well. Frankly, overall, only 60% of the women in Medicaid are getting a postpartum visit, and they tend to not be very good visits. So again, I say, if the states adopt it, it's up to us to build it and implement it in a way that will make a difference.
Yes, you are exactly right. Let's see, we have one that asks, are there specific pieces of legislation on supporting the use of midwives instead of OB-GYNs?
Yes, there absolutely are. There are several. There's one specifically focused on using doulas. There are others that really include strong provisions in midwives. They are both in the Momnibus and in that other list. I will make a note to myself that I can find some of the bill numbers, and we can post a few of those in the follow-up. But there definitely are. There is a lot of emphasis in the legislation pending in Congress about, again, using doulas, using midwives, using community health workers, reducing bias among the providers that we do have. A lot of workforce issues are embedded in those bills. People heard us. The members of Congress heard us. And they heard you talking about the workforce issues, and they really have included it in the legislation. Really good question.
Yeah, that's amazing. And if you could please share those bill numbers, and I'll be sure to include that in the follow-up email that goes out with like your slides and the recording. Okay, so let's see here. What else do we have? Is the child tax credit only distributed during tax time, or is this monthly income?
So if families are known to the IRS, they will start getting their checks in July. And that's why I said there's a sense of urgency. So if they filed taxes last year, they will start getting those $300 or $350, $360 a month checks this July. Others who are not known to the tax system may have to wait until their tax filing early next year, but we have time to get families into that system. The IRS has really opened the door. They've got websites. The link to the website is in my slides. We could help families go there and fill out a form that gets them to start the checks before, so they don't have to wait till, let's say, next April.
Yes, that is excellent. Let's see. Are any of the federal policies that were listed previously bipartisan, or are they predominantly introduced by Democratic legislators?
They are predominantly introduced by Democratic legislatures, but there are a few Republicans in the House and a few Republicans in the Senate. Some of them introduced their own bills. Senator Portman has a bill. He introduced one last session, and he introduced one this session. Last session, he introduced it with Senator Stabenow, and that was a nice pairing, Senator Stabenow from Michigan and Senator Portman from Ohio. He's reintroduced a bill himself right now, and Senator Stabenow, she's got the vaccine bill. There are on both sides in the House and in the Senate a few members. So the overall effort, we can clearly say, is bipartisan. And there isn't. So my concern was that if Republican members of Congress started introducing bills, they would be watered down, or they wouldn't set out on high priorities of the kind that some of the other bills have. But I don't see much watering down, and like in what Portman has introduced. I mean, it's not the Momnibus, but it's clear, specific, it's work that needs to be done. It's on target. It's not just a watered down, in name only kind of bill.
That's great. That's really encouraging. So bouncing back to the child tax credit, I missed this question while we were talking about it, but somebody would like to know if there are criteria to receive the checks beginning in July.
Well, again, the estimates are that 90% of all families qualify. So if you're really rich, you don't qualify. And so that 10% of families who have real wealth and very high incomes do not qualify. The other families who are not going to consistently qualify are families with mixed immigration status. I don't have time. I didn't use time to go into that today, but I will tell you that. And you can find materials, particularly at datadiversity.kids, and I know datadiversitykids.org. Sorry. Can you type that in, Lynn? I know that Dolores Acevedo Garcia has been speaking about this. She's got some good pieces on it. There also are other organizations, but if you Google child tax credit and immigration, you will find a lot of organizations that have come up with things. I think the analysis by datadiversitykids.org is really, that's it. Thank you, Len. I always say it backwards. diversitydatakids.org. I'm going to say it right. Lynn has put it in the chat. You can go there. They have several blogs. They've got some data analysis, and other organizations do as well. If you need to know the specific details of which kind of mixed immigration, it does more than the child tax credit used to do for families with mixed immigration status. Yes, and they also have the interactive maps on the Child Opportunity Index. And those really can be useful to you when you're trying to make the case locally.
And there was another follow-up question about the child tax credit. If your child was born in 2021, would they qualify?
Yes. Yes, but you're going to have to make yourself known to the IRS. They didn't pay attention about whether or not you got a new baby.
Okay. And to switch gears a little bit, we have a question that asks, do you think there is a beneficial way to advocate for more quote unquote liberal policies in highly conservative areas?
I think there are some windows of opportunity here. So one that I think there is, and I'm just going to say to you, the first 3 states that took up the postpartum expansion were Florida, Texas, and Missouri. Right? The first 3 legislatures that went for the postpartum expansion were Florida, Texas, and Missouri. Why did they go for that? Because they don't want to expand Medicaid overall. They don't want to adopt the Affordable Care Act expansion of Medicaid for many more poor adults, but they want to look good and they want to look like they did something. So in those more conservative states, those are 3 of the most, particularly Florida and Texas, they're 2 of the most conservative states in the country in terms of Medicaid policy. That they ran. I mean, they just ran after this, and to have them be some of the first out of the gate tells us that if you live in a more conservative state, you have an opportunity at that, even if you don't have an opportunity to extend that coverage in Medicaid for women, for poor women with moderate incomes there across the life course. You could at least get them postpartum coverage so they don't fall off. And in those states, if there's some of the states where, 60% of the women fall off because their regular Medicaid level is so low. Once the woman's not pregnant, she hits the 60-day postpartum, 50, 60, 70% of women are going to lose their Medicaid coverage postpartum. So there's not only an advantage with conservative lawmakers, there's a huge advantage for those women to get them that coverage in the first year. I'm going to answer a question that nobody asked because it's one of my favorite topics that I didn't go deeply into, but I told you about the missing baby report. And one of the things that I see is where your state's going to start a year's worth of postpartum coverage and a year's worth of infant coverage. That's without renewals. That's without special application. That's without people falling off. Let's get those diettes. Let's get those moms and those babies covered for that whole year and build systems of care and services that protect them both for that full year. It's a tremendous opportunity for us to think about moms and babies together for a change.
Yeah, I absolutely agree. And we have a question about measures, and it says, what measures can be used to best identify patient provider gaps in medical services to address equity.
Well, that's those dark purple, that dark purple row that I had on my measurement slide. I'm just gonna, if I can, Lynn, I'm gonna put that slide back up for a moment.
Yeah, go right ahead.
Okay, it's right here. So a lot of times, right, we're only measuring what's on the top row here. We're measuring infant, fetal, maternal mortality, preterm birth, low birth weight birth, small for gestational age, SIDS to weeds. I mean, those are kind of the outcome things that we typically measure, and not all of them. And then I'm in this process where we used a lot of experts in the field to create this framework. We've got these domains that have to do with equity and social determinants, including racism in this batch. And then down here, keying off of unequal treatment and health equity, we want to be measuring utilization and we want to be measuring coverage, but we want to identify, and we might, this was done 3 years ago, 4 years ago, we might want to adjust these now, like I would take out 17P, but saying, what are the sentinel care opportunities? So measuring these things by race, ethnicity, by income and health insurance status, we're going to see the unequal treatment in those data if we look, but we haven't been looking. And then the other thing to do in this is to have quality improvement projects that really, again, look for the equity issues, are designed to focus on measuring where we're likely to see disparities. And then the third one that I mentioned earlier, and that is there are data to document unequal treatment in your PRAMS data sets. I cannot get to them from where I sit. CDC doesn't often do the analysis of the whole set, but you people in Region 5 could mine the PRAMS data sets to show disparities by Medicaid insurance status, disparities by income, disparities by race, ethnicity, like that little graph I showed you about who did and didn't get preconception advice and care, who did and did not get prenatal advice and risk appropriate services. Those things are in your PRAMS data, and most states just aren't routinely pulling them up. And we could start doing that. And again, that's going to give us the data to say, look at this unequal treatment. Look at this gap between women who got advice and women who didn't by race. Look at this gap between women who got standard of care counseling for prenatal services, like breastfeeding. Look at, it's not the same by race and ethnicity. It's not the same by Medicaid and non-Medicaid status. And whether that Medicaid is indicating insurance status, income, or race, or all three, we ought to just be pulling up the data and using it to start hammering away at what I call the issue of unequal treatment. It's another way to combat bias where we have good data and we can drive the question of bias with data on unequal treatment.
Yes, I could not agree more. PRAMS can be such a gold mine of information, and there's so many different crosstabs that you can do with PRAMS data. Thank you. Okay, so we have a request to see the slide on how to apply for the child tax credit. They were wondering if you could show that again.
Oh, my slide didn't actually say how to apply, but let's see what we can do here. I'm going to share the screen. Let's just walk through something hypothetical. So first of all, you get to see the pretty butterfly in my screen. And second of all, we're just going to go in and we're going to say, I'm going to say child tax credit, IRS. Oops, I can type IRS. Okay, and so then you're going to go right in, find the IRS portal, and you're going to see that they're going to tell you really step by step. And look here, big letters, non-filers, submit your information. If you aren't required to file a tax return and you haven't given us your information, you need to give us some information. And families can then click and enter their information and they get the tool. When do I get my check? who should use this tool. Not every family at every literacy or every internet literacy is going to be able to walk through this on their own, but it's relatively straightforward. And I think we could help people do this. Again, how does it work? What do you need? You need your name, your mailing address, an email address, your valid social security number, a bank account if you have one, and then these are people who filed their taxes. They got a special PIN number, but it's just really, again, for any of us who routinely fill out forms online, the IRS has made it relatively simple, and so here, that's the advance. That's to get your tax credit in advance. And here's they even have that, if you didn't get your stimulus check, they've got a get my payment tool. Where's my money? I didn't get my $1,400. And then they've got a whole piece to walk through EITC. But the child tax credit is the big one. And again, it'll tell you exactly what you need to get the advance payments, and then how they can automatically enroll you. So I Googled child tax credit, IRS. It's there.
Thank you, Kay. That was very helpful to see. And it is nice that, the IRS tries to lay it out like, this is what you need. This is the information we're asking for. Click this button. Yeah. So that is quite nice.
Yeah.
And hopefully members of our audience are able to help folks who maybe can't access internet or don't have the tech literacy to be able to do something like that online. So thank you for showing us that. And we don't currently have any other questions in the chat box or in the Q&A function. So if there's anybody with any additional thoughts or questions that have come up throughout our discussion time or throughout Kay's presentation, please feel free to make use of the Q&A box or the chat box. We have another 15 minutes left scheduled of Kay's time, so here is your chance.
So I guess I would say, I would encourage you, I would go fast over those big, large P, small p, program and practice slides, but I think us really thinking in a sophisticated way about what are the big piece challenges, and those of you who do direct advocacy or talk to your state lawmakers or members of Congress, thinking about that big P policy advocacy and what can change. But then that small p policy advocacy, all the things you can do, some of them without new money, some of them without any expansions of coverage, some of them are just about changing the way we do our business, and really involve systematic change. You all in Region 5, from your earliest days in COIN and before through now, you're some of our nation's leaders at the state and local level on doing this work, and we're going to count on you to show us the way. Again, still more in implementing these policies to help families get out of debt, not get evicted, to keep their babies safe, get this coverage postpartum, as well as then that other whole layer of shifting the care system and really getting a focus on equity, anti-racism, and equal treatment. I just think we have tremendous levers that we've not yet used, and we have new levers in these policy changes. Any other questions?
There was one additional comment that we received that wanted to highlight bias in disability. And so it says, when speaking of unequal and inequitable treatment, it is also fair to call out that family units are experiencing disabilities and COVID as a disability condition. And so also family members receiving Medicaid due to disabling conditions and the implementation of unfair practices and not getting a standard of care inside and outside of the disability.
Absolutely, and I can't see, I could see, it's Peggy. Peggy, thank you for mentioning that. that actually is something I talk about in other places. I tried to squeeze a lot in here about maternal and infant health because that's what I was primarily asked to focus on. And both as a faculty member for a LEND program here in New England, and overall in my career, I've done a lot of work on disability issues. I've got a lot of details about the home and community-based service waivers, and particularly out of the AUCD and our disability policy seminar. I would encourage people to go to again, Google disability policy seminar if this is an issue you want to know more about. There were fantastic presentations from people at the White House and HHS and Medicaid, as well as a lot of disability advocates and self-advocates talking about the exact challenges that you're describing, about people not getting equal care or equal access, or about discrimination in the way that people with disabilities of all ages were treated in our healthcare system in the COVID era. It also, you know, it's among the priorities of the Biden-Harris administration, and the emphasis in Congress on getting more done through home and community-based waivers, so people have more opportunities to stay in their home, to have caregivers, to be paid family caregivers for their loved ones. All of those things, and in the context of Medicaid, are there. But you're absolutely right. I think about the equity issues broadly. Many of you know I came from a very poor family. My family had been poor for 300 years. I'm the first person in my family to ever not be poor, in essence. And I think about the income, the disability, the race, ethnicity. I just think racism in particular, you know, compounding all of the other factors that lead to discriminatory practices for people. But certainly disability is there as well. It's harder to see a person's income, but we know that income affects all kinds of things, and that's why the EITC and the child tax credit work to change families, because it's about having money to do things and making your own decisions and making your own way for your children and yourselves.
Yes, thank you, Kay. And I know that the conversation around vaccinations and like lifting, you know, different mask mandates and this and that raised a lot of concern for the disability community as well. And so very important to include that in our conversation about, you know, equity and justice in public health. And
Thanks,
so
Peggy.
we have about 10 minutes left. I don't see any other questions in the Q&A or in the chat box. So unless anybody has any last minute burning questions or anything that they want to bring up to Kay, we'll go ahead and bring our session to a close. Kay, thank you so much for joining us this afternoon and sharing your expertise on policy and on bills and legislations, because it can be so daunting, you know, even if we're public health professionals, we're educated and all of this stuff, but it, like, legislation can be just a whole nother beast, right? And so it is always so helpful to have somebody kind of distill it and just say, like, these are the parts that matter for what we're trying to do in our work. And so it's very helpful to hear. Thank you so much. Oh, we have one last question.
Good.
They submitted one last question before submitting their question, so I'm waiting on their question.
Okay. So I really, again, I just want to say that thanks to all those in Region 5 who have pushed us, who have led. You know, again, I'm humbled to follow Art James in this series. I'm grateful to Arden Handler for always keeping me up to date about what those wily and effective Illinois advocates are doing. I do some work with folks in Michigan around perinatal issues from time to time. I used to keep up a little better on Wisconsin, and I'm always trying to, you know, wish that my home state of Indiana would do better than they did. Some of you may or may not know, but Indiana was the last state to adopt Medicaid DPSTT benefit, and they didn't do it for 10 years. And if they had adopted it when other states did, I would have had health care when I was a kid, and I didn't. So I kind of hold a grudge about that. I think implementation is everything, people. And we've got to get these things to grab hold so that families understand they don't want to give up the child tax credit. They don't want to give up the additional home visiting. They don't want to give up that coverage that they need after they have a baby. If they don't have it, they won't know that this administration and this Congress brought it forth. And we need to help them have it and see the benefit of it, and that can change our politics.
Yes, exactly. And so our question did come in, and this person would like you to reiterate on the child tax credit. If the IRS knows you, will you need to apply, or is it only if they don't know you?
If the IRS knows you, you do not need to apply. If the IRS knows you and your child, right? So not if you just had a new baby, not if you didn't file your taxes. So yes, if you file taxes in 20 or 21, the IRS knows you and they're going to send money.
Okay, excellent. Thank you so much, Kay. And
Great.
thank you everyone in the audience for joining us. This session was recorded, and I'll follow up with the different things that Kay had mentioned in her presentation in a follow-up email in the next few days.
Thanks to my friends at CityMatCH. Bye-bye.
Thank you, Kay. Have a good afternoon, everyone.